So now we're going to start talking about medications for dementia. These include the medications for Alzheimer's disease, which is a chronic neurodegenerative illness characterized by cognitive and functional decline, as well as emergent behavioral disturbances. Currently, the cholinesterase inhibitors such as donepezil, Aricept, Esalen, Razidine are the standard therapy for AD. The 3 cholinesterase inhibitors are medications that are currently available specifically for the treatment of mild to moderate dementia of the Alzheimer's type, with Aricept also approved for severe Alzheimer's disease. These drugs do not cure the disease, but they may slow the progression of the disease and at best may modestly improve function. These medications are often initiated in primary care for patients who meet the criteria of mild to moderate Alzheimer's type dementia, or they may be initiated after consultation with a provider who specializes in geriatrics or with neurologists or psychiatrists. Dementia is also available for moderate to severe dementia. It is the first N-methyl disaspirate receptor antagonist, which is a subclass of the medications that have a different mechanism of action from the cholinesterase inhibitors. Dementia may slightly improve function, reduce care dependency, and may slow the clinical decline in patients with moderate to severe dementia. Those who are stages 5 through 7 of the global deterioration scale, who have a mini mental status exam of less than 10. It may be given in addition to Aricept or as a monotherapy. Medication treatment for Alzheimer's disease is a topic of intense research, and it is limited by our lack of understanding and causes as well as pathology of the disease. No drugs as of now have been found that prevent or reverse the degeneration of neurons. However, these drugs may help to improve quality of life of these patients. So looking at the drugs, these are the cholinesterase inhibitors. These treat mild to moderate Alzheimer's type dementia, and these again are often initiated by the primary care provider or after a consultation. Then we have the NMDA receptor antagonists for moderate to severe Alzheimer's type dementia, and these may be given in addition. They may also be initiated by the primary care physician or after a consultation. Well, looking closely at the mechanism of action, the cholinesterase inhibitors act by blocking the enzyme that degrades acetylcholine in the brain. This results in more acetylcholine in the hepatic cleft and may enhance cholinergic transmission. The intended effect is to diminish signs and symptoms of dementia, thereby improving function and slowing the progression of the disease. They might also delay the need for nursing home placement. The effectiveness of the drug wears off as the disease progresses, as more neurons are destroyed, and no evidence suggests that these drugs alter the disease process or cure the disease. Although these drugs may diminish symptoms, when the medications are stopped, symptoms return and the patient may soon become as symptomatic as if they had never taken the drug. The NMDA receptor antagonists is linked to learning and memory. The receptor is linked to learning and memory and is stimulated by glutamic acid, the principal excitatory neurotransmitter. Excessive stimulation of the NMDA receptor, however, leads to excitotoxicity. Blocking of this receptor is thought to prevent cognitive damage in patients with vascular dementia. Memantine, one of the NMDA receptor antagonists, blocks the excitotoxic effects associated with abnormal transmission of glutamate. It may improve overall patient function slightly, but there's no evidence that indicates that it prevents or slows down neurodegeneration. So what are the treatment principles? Evidence suggests that the cholinesterase inhibitors stabilize the cognitive and functional ability for approximately 1 year. Tacrine is not widely prescribed because of the need of frequent liver monitoring and 4 times a day dosage. Approximately 1/3 of those treated with cholinesterase inhibitors exhibit a modest improvement in cognitive testing scores, function, and behavior. 1/3 show no change, and 1/3 are not able to tolerate the medication because of adverse effects. Donepezil, glutamine ER, or the rivastigmine patches are considered first-line therapy because they allow once-a-day dosing. Treatment should be started 5 milligrams a day, which, if tolerated after 4 weeks, can be increased to 10 milligrams daily or even as high as 23 milligrams daily. Aricept may be better tolerated than the other inhibitors and is more common. One study showed that patients with moderate to severe Alzheimer's disease found that those who continued taking Aricept experienced significant cognitive and functional benefits compared with patients who stopped taking the drug after 3 months. Although these inhibitors have proved effective stabilizing symptoms, it appears that in clinical practice that patients receive treatment with only one inhibitor for a short period of time relative to the long-term course of Alzheimer's disease. For example, in the United States, the average total duration of treatment with Aricept is less than 200 days, which is of concern given the fact that the disease course on an average lasts approximately 7 to 10 years. A proportion of patients with Alzheimer's disease fail to attain sustained clinical benefit from the inhibitors treatment, mainly because of lack of initial efficacy, loss of efficacy during long-term treatment, or the occurrence of safety tolerability issues. In most instances, once a treatment is thought to be ineffective or poorly tolerated, the trial often is considered definitive and treatment is stopped altogether. As many patients with Alzheimer's disease are being given up on early in the course of their illness because no alternative treatment is offered. Currently, if treatment with certain inhibitors fail to provide initial or sustained efficacy or is associated with poor tolerability, patients may still benefit from another drug in the class. Patients who should be switched include those who show initial lack of efficacy, initially respond to treatment but subsequently fail to benefit or experience safety or tolerability issues. Every effort to increase the dose to maximum efficacy or decrease the dose to reduce side effects should be made first. Switching should be considered only after a minimum of 6 months treatment, beginning when the optimal dose of the initial medication is reached. Treatment evaluation should be based on realistic objectives. The patient is not going to be cured from this disease. Follow the guidelines for the medication. Some drugs require a drug-free period to quote, wash out the drug before the new drug is introduced. Remember that all of these medications are metabolized by the cytochrome P450 hepatic enzyme system and have the potential for drug interactions. Interactions can occur with anticholinergic medications or cholimimetics. These drugs must be used with caution, if at all, in patients with concomitant myasthenia gravis. Patients with moderate to severe dementia, stages 5 through 7 of the Global Deterioration Scale, or a mini mental status exam of less than 10, may be started on memantine, which may be given with Aricept. Slight improvement in function, reduction of dependence of caregivers, and slowing of clinical decline has been seen in these patients. Some controversial studies suggest that patients with long-term aspirin or nonsteroidal anti-inflammatory use may have some reduction in the incidence of Alzheimer's disease. Other evidence suggests that vitamin E slows the progression of Alzheimer's type dementia by protecting cell membranes from the oxidative damage of free radicals. Still, other studies are examining whether diet may have a protective or harmful role in the origin of Alzheimer's disease. Again, active research continues on this disease, and there is no cure. If the patient cannot tolerate a cholinesterase inhibitor because of GI or cardiac effects, the sole NMDA receptor antagonist can be used alone. For evidence-based recommendations, the evidence is insufficient to compare the effectiveness of different pharmacological agents for the treatment of dementia. However, an overview of research suggests that Aricept improves cognitive function and global clinical state for up to 2 years in patients with mild to severe Alzheimer's disease. Quality of life was improved at 24 weeks. Aricept given to patients with more severe dementia produced improvement in cognitive function at 24 weeks, and research does suggest that Aricept delayed the median time to clinically evident functional decline by 5 months. In one study with patients with Alzheimer's disease, they found no significant difference between Aricept and glutamine in cognitive function or adverse effects at 1 year. Ginkgo biloba and memantine are likely to be beneficial. Antidepressants given to Alzheimer's patients with depression appear not to be effective and can cause adverse effects or introduce unwanted drug interactions. For the cardinal points of treatment, early diagnosis and initiation of treatment may delay the disease progression. Brief screening tools at primary care visits with further evaluation of selected patients if needed is effective in diagnosing cognitive disorders. Evidence from various trials suggests that cholinesterase inhibitors stabilize cognitive and functional ability for about 1 year, and pharmacological treatment should begin as soon as the disease is suspected. Clinicians should base the decision on initiating a trial of therapy with cholinesterase inhibitors or memantine on individualized assessments. Clinicians should base the choice of pharmacological agents on tolerability, adverse effect profile, ease of use, and cost of medication. Depression and/or delirium should be identified and treated. Patients should avoid medications with sedating or anticholinergic side effects because drugs with these side effects contribute to falls in the elderly. Avoid polypharmacy. Use the least number of medications at the smallest doses, including over-the-counter medications. Treat any metabolic disorders, infections, or comorbid diseases as soon as possible, and advise patients with dementia to avoid alcoholic beverages. Antipsychotics may be used in some settings to manage Alzheimer's disease symptoms, although their use is controversial and should be used for no longer than 6 months. Abruptly stopping risperidone may double the risk of Alzheimer's disease symptom relapse. For again, for patients with mild to severe dementia, may be started on memantine. They may be given Aricept at the same time. You need to identify the presence of depression or delirium, avoid medications with sedating or anticholinergic effects, and treat those metabolic disorders, infections, and comorbidity as soon as possible. For non-pharmacological treatment, you need to educate the caregivers regarding behavioral and environmental management, recommend caregiver support groups, and use community resources, including respite care. New research does suggest that caffeine consumption may reduce the risk of Alzheimer's disease because of its ability to bind to cerebral adenosine receptors, and regular exercise in seniors can reduce the chance of developing vascular-related dementia by 40% and cognitive impairment by 60%. How do we monitor these patients? A variety of cognitive assessment tools are available to monitor therapeutic responses to treatment. The most commonly used standardized assessment tool is the Folstein Mini Mental State Exam. The Global Deterioration Scale can be used to stage dementia based on functional ability. The CATS assessment of activities of daily living and instrumental activities of daily living are used in monitoring improvement or decline in function. Clinical evaluation and family observation of behavior and function may be the most useful and reliable monitor of therapy. Because the liver metabolizes these drugs, periodic monitoring of hepatic function may be justified, particularly in those receiving multiple medications and in those with weight loss, anorexia, nausea, vomiting, and abdominal pain. These are signs and symptoms that may suggest hepatic dysfunction. You need to monitor the CBC and routine serum chemistries for toxic adverse events. Monitor heart rate and blood pressure, particularly in patients with cardiovascular disease. Monitor for signs of toxicity such as vomiting and diarrhea, diaphoresis, urinary incontinence, psychosis including hallucinations, nervousness and behavioral changes, tremors, and weight loss. Changes in these symptoms are important to follow. If exacerbations occur, consider adjusting the medications or looking for other potential causes. It's important to note that visual hallucinations are a hallmark feature of Lewy body dementia. For patient education, you need to caution the patient and the caregivers not to change their dosage without consulting their healthcare provider. Advise of initial and long-term delayed side effects. GI side effects are common. Sleep disturbances may be addressed by changing the time of medication. Advise of purpose, expectations from treatment, and time frame to note improvement and remind the patient and the family that this is not a cure. Counsel the family regarding behavioral and environmental management of the disease. Advise the patients regarding long-term care, including in-home services, adult daycare, assisted living facilities, and nursing homes. These patients are a lot of work, and family members can become very overwhelmed by the disease. Aricept is typically taken in the evening just before going to bed, but in patients experiencing sleep disturbances or nightmares, daytime administration is preferred. Aricept or memantine may be taken with food or on an empty stomach. The patient or the family member needs to inform the healthcare provider of medication if they are going to have surgery. The patient should avoid eating grapefruits or drinking grapefruit juice concurrent with the medication administration because of its effects. For patients' variables, geriatrics, age does not influence the metabolism or clearance of cholinesterase inhibitors. However, reduce the dose and use glantamine and mementine with caution in patients with severe renal impairment. Creatinine clearance of 5 to 29 milliliters per minute. Pediatric patients' efficacy has not been established for any dementing conditions that occur in children. These drugs are used in head injuries in children. For those pregnant and lactating, Aricept is category C, and the rest of the medications are considered category B. There are no controlled studies of these drugs in pregnancy, and it is unknown whether these drugs are excreted in breast milk. Gender, it has been noted that the plasma concentrations are up to 50% higher in women. They might require a dose adjustment. So now we're going to move on to antiepileptics. The anticonvulsants or antiepileptic drugs are the medications used to control seizures. Traditionally, these drugs were divided into 5 classes, including hydantoins, gamma-aminobutyric acids, or GABA analogs, succinimides, barbiturates, and benzodiazepines, plus a miscellaneous class. In addition, the diuretic actazolamide is used to adjunctively manage seizures. These medications may be used alone or in combination, but the different medication classes are unrelated chemically. Currently, the medications tend to be classified as old drugs, which include the first 5 classes of drugs, plus carbamazepine from the miscellaneous class. The remainder of the miscellaneous class consists of the newer drugs. Over time, these drug classifications have become less popular, with many clinicians preferring to classify medication as older or newer drugs. The newer drugs are not particularly more effective, but they have fewer side effects or drug interactions because they are less involved in the induction or inhibition of the hepatic P450 enzyme systems. Some of the newer drugs are also used for treating patients with problems other than seizures, such as peripheral neuropathy and pain management. Many of the newer AEDs are approved for adjunctive use only. In general, seizure disorders are managed by specialists rather than primary care settings. The primary care provider often monitors these patients once they are stable and may see them for other acute or chronic medical conditions. So the classes of drugs, here is a list that many of you may be familiar with. These include the 6 classes and indications: generalized tonic-clonic or absence seizures, the partial, simple, partial, complex partial, or partial with secondary generalization seizures. Then you have the complex, secondary, generalized, and absent seizures. Mechanism of action for these drugs. All medications increase the threshold of the CNS to convulsive stimuli or inhibit the spread of seizure activity. For most of these drugs, the exact mechanism for reducing seizure activity is not clearly understood. However, all increase the threshold of the CNS to convulsive stimuli or inhibit the spread of the seizure activity. What is known about the specific mechanism of action is not clearly understood. However, there is some evidence showing that the hydantoins, the primary site of action appears to be in the primary motor cortex, where spread of seizure activity is inhibited. Phenytoin prolongs the effective refractory period by blocking neurosodium channels. It stabilizes the threshold against hyperexcitability caused by excessive stimulation or environmental changes, and reduces the maximal activity of brainstem centers responsible for the tonic phase of grand mal seizures. It also exhibits antiarrhythmic properties similar to those of quinidine or procainamide, although it has little effect on the electrical excitability of cardiac muscle. Phenytoin decreases the force of contraction, depresses pacemaker action, and improves arterioventricular conduction, particularly when it has been depressed by digitalis glucosides. The GABA analogs, the mechanism of action of valproic acid and the newer GABA analogs is not clearly understood. All of these drugs are chemically unrelated, but they increase the actions of GABA, an inhibitory neurotransmitter. They may inhibit the voltage-dependent sodium channel, thereby stabilizing the neuromembranes. Some of the newer GABA analogs have several actions, including augmentation of GABA, blockage of voltage of sodium channels, antagonism of glutamate, and modulation of calcium channels. The carbamazepine is chemically similar to the tricyclic antidepressants. It is unrelated structurally to all other antiepileptics. Its action is similar to that of phenytoin. It limits seizure propagation by blocking postsympathetic transmission. The barbiturates, phenobarbital, works by inhibiting depolarization of neurons by binding to the GABA receptor. This enhances the transmission of chloride ions. Barbiturates also increase the threshold of electrical stimulation of the motor cortex. Primidone is one that's metabolized to phenobarbital and phenylethylamide. This has anti-epileptic activity. The phenylethylamide, or PEMA, may potentiate the activity of phenobarbital. The benzodiazepines work similarly to barbiturates, but they also increase the number of chloride channels when facilitating transmission of chloride ions. This suppresses the spread of seizure activity, but does not eliminate abnormal discharge from a focus. Initiate maintenance antiepileptic therapy after seizures have stopped. For the gabapentines, they act on voltage-gated calcium channels, specifically in the alpha-2 delta-1 subunit. The channel appears to be located presynaptically and may modulate the release of excitatory neurotransmitters that participate in the genesis of epilepsy. New extended release tablets are now available. However, these drugs are not interchangeable with each other or gabapentin because of differing pharmacokinetic profiles. The pregabalin medications bind to the alpha-2 delta subunits of voltage-gated calcium channels with the CNS, inhibiting excitatory neurotransmitters release, and the topromate is anti-epileptic activity may be due to a combination of potential mechanisms. This blocks neurovoltage-dependent sodium channels, enhances GABA A activity, antagonizes AMPA, glutamate receptors, and weakly inhibits carbonic anhydrase. So as you can see, with all of these medications, they're heavily dependent on the calcium and sodium channels for their action. So what are the cardinal points of treatment? You need to choose an appropriate agent for the type of seizure. Most of these patients are seen by neurologists, and they usually initiate the medications. However, some of you may be in the position in which you need to choose the appropriate agent, and this will depend on the seizure type. Choose the least toxic option. Most older antiepileptics are cytochrome P450 inducers, and as such are involved in many drug-to-drug interactions. Initiate monotherapy, start slowly and continue until steady state is reached, 5 times the half-life, and titrate the dose upward until control is achieved or adverse reactions occur. Choose an alternative monotherapy drug if adverse reactions to the first drug occur. Do not discontinue abruptly because of the possibility of increasing seizure frequency. Therapy should be withdrawn gradually to minimize the potential of increased seizure frequency unless safety concerns require a more rapid withdrawal. All current AEDs pose an increased risk of suicide in these patients, as defined as suicidal ideation and behavior, and prescription should be accompanied by a patient medication guide describing the risk. Patients with status epilepticus who are given midazolam through an auto-injector rather than IV lorazepam are more likely to be seizure-free by the time they arrive at the hospital, and are also likely to require hospitalization. For the pharmacological treatment, the decision to initiate an anti-epileptic therapy must be made with consideration of several variables. Most important are the consequences of seizure reoccurrence for the patient. These consequences are mainly psychosocial and may depend on age, employment, family responsibility, and access to transportation. Make the decision about drug therapy in consultation with a primary care physician, the neurologist, and the patient, as well as the family. A seizure is usually self-limiting in its physical consequences unless the patient suffers physical injury during the seizure. However, research has shown that people who have seizures are at increased risk of sudden death, slowing of cognition, and loss of short-term memory after a seizure, and the heavy emotional burden carried by patients who fear that suddenly may have a seizure. Patients who have seizures may live with state regulations such as those that limit their driving, require careful family planning, and control their environment for maximum safety during a seizure. The goal of medical treatment is to control the seizure and allow the patient to return to their usual activities. Ideally, this should be done with a single medication that has no significant side effects. This is achieved in about 1/2 of the patients. The medication to use depends on the type of the seizure. A neurologist generally makes this decision. The medication is started at a low dose and is gradually increased until seizures are controlled or patient exhibits adverse effects. If a patient continues to experience seizures despite the highest tolerated dose, a second drug is added gradually. Then the first drug is withdrawn gradually. The use of complementary or alternative medicine may interact with other anti-epileptic drugs and must be used cautiously and with the knowledge of the healthcare provider. Discontinuation of anti-epileptic medication may be considered in patients who have been seizure-free for longer than 2 years. An EEG should be obtained before medication is withdrawn. The recurrence rate is usually about 40%, with most seizures occurring in the first year after medication is discontinued. The same psychosocial factors and risks of seizures recurrence for the individual patient should be considered when antiepileptics are withdrawn as when therapy is initiated. No evidence suggests that prophylactic antiepileptic treatment prevents epilepsy. It is common practice to give an antiepileptic, usually phenytoin, at the time of neurosurgery and after head trauma. Most survivors of brain surgery or head trauma do not later develop epilepsy. Phenytoin given at therapeutic doses during the week after severe head trauma does suppress seizures. This treatment is appropriate when the brain is swollen and cerebral blood flow may be compromised. A seizure could further compromise cerebral blood, leading to increased swelling and increased intracranial pressure. The same treatment can be applied to the perioperative period. However, no evidence indicates that antiepileptics prevent later epilepsy. Therefore, it's not necessary to give long-term antiepileptics to these patients. Those individuals who have status epilepticus may experience true medical emergencies. As primary practitioner must be prepared to recognize and manage. For practical purposes, status epilepticus is defined as 2 or more seizures that occur without complete recovery of neurological function between seizures, or as continuous seizures activity for longer than 5 minutes. Therapy should be initiated for any generalized tonic-clonic convulsive seizure activity. This is formally referred to as a grand mal seizure. Most generalized convulsive seizures last less than 2 minutes. As the practitioner who witnesses a generalized convulsive seizure for longer than 2 minutes should be prepared to initiate emergency procedures. These include activating emergency medical services, protecting the airway. Emergency personnel should initiate IV access and administer IV benzodiazepine, either lorazepam or diazepam, as protocols permit. Phenobarbital is effective in prevention of febrile seizures in children, although long-term prophylactic treatment for febrile seizures is not recommended by the American Academy of Pediatrics. They conclude that the risk of long-term treatment outweigh the benefits. In general, treatment is reserved for those children at greatest risk for further neurological problems because of the seizure. These include children with febrile seizures before 18 months of age, those with neurologic dysfunction or severe developmental delays, those with complex seizures, and those who have seizures with a focal component that lasts longer than 15 minutes. Although older generation AEDs such as carbamazepine, phenytoin, and valproic acid continue to be used widely in the treatment of epilepsies, these drugs have important shortcomings, such as highly variable and nonlinear pharmacokinetics, a narrow therapeutic index, suboptimal response rates, and a propensity to cause significant adverse effects with drug interactions. Compared with older agents, some of the new AEDs offer appreciable advantage in terms of less variable kinetics, and particularly in the case of gabapentin, levetiracetam, and vigabatrin, a lower drug interaction potential occurs. Currently, new generation antiepileptics are used primarily as adjunctive therapy for patients who are refractory to the older agents. However, because of advantages in terms of tolerability and ease of use, some of these drugs are used increasingly for first-line management in a certain subgroup of patients. As a result of serious toxicity risks, valbenate and vigabatrin should be prescribed only for patients who are refractory to other drugs. Because hepatic metabolism is often the cause of pharmacokinetic drug interactions, enzyme-inducing drugs such as the phenytoin, phenobarbital, and carbamazepine readily enhance the metabolism of other antiepileptics. However, many of the newer agents do not undergo hepatic metabolism, and this allows for reduced drug-to-drug interactions. Enzyme-inducing antiepileptics also enhance the metabolism of many other drugs, such as oral contraceptives, antidepressants, and Coumadin, so that the therapeutic efficacy of co-administered drugs is lost unless the dosage is increased. An increased risk of suicidal thoughts and behavior has been observed for most antiepileptics. Monitor all patients for notable changes in behavior that may indicate suicidal thoughts or depression. Again, as a primary care provider, you must be prepared to recognize and manage seizures if they occur in the office and last greater than 2 minutes. You need to protect the airway, support the airway, and initiate the emergency system. How do we monitor these medications? The patient who is beginning anti-epileptic therapy must be monitored frequently to confirm that the drug is in the therapeutic range, to document adverse events, and to maximize seizure control. These drugs have individualized therapeutic ranges above which most patients will experience toxic effects. If the therapeutic range is too low, most patients will not have adequate seizure control. However, individuals may do better with drug levels above or below the therapeutic range. Monitoring of serum drug levels usually must be done yearly for the patient who has been maintained on an anti-epileptic. A serum level should be checked when seizure frequency increases or compliance is an issue, or if the patient is exhibiting toxic signs. Many medications interact with metabolism of anti-epileptics, therefore serum levels of the anti-epileptic should be checked when medication changes are made. Ideally, a trough level should be drawn for routine monitoring. A random level should be drawn when seizures occur. Some of the older anti-epileptic drugs have a relatively long half-life, so once steady state is achieved on a maintenance dose, little fluctuations in serum levels should occur. The older anti-seizure drugs are metabolized by the liver. However, many of the newer agents do not undergo hepatic metabolism. This allows for reduced drug-to-drug interactions. Hepatic enzymes should be checked before anti-epileptic therapy is initiated. It's common for hepatic enzymes to be mildly elevated in those on anti-epileptics. They should be monitored yearly and more frequently in patients with known hepatic dysfunction. Children younger than 10 years of age who are on valproic acid should be monitored closely for hepatotoxicity. The most significant pharmacodynamic interaction is that of lamotrigine, LTG, and valproic acid. These drugs exhibit synergetic efficacy when co-administered to patients with refractory, partial, and generalized seizures. Because hepatic metabolism is often the cause of pharmacokinetic drug interactions, enzyme-inducing drugs such as phenytoin, phenobarbital, and carboxyl readily enhance the metabolism of other AEDs. Enzyme-inducing AEDs also enhance the metabolism of many other drugs, such as oral contraceptives, antidepressants, and warfarin, so that the therapeutic efficacy of co-administered drugs is lost unless the dosage is increased. Valproic acid inhibits the metabolism of phenobarbital, resulting in elevation of plasma concentrations of inhibited drugs and consequently of increased risk for toxicity. Inhibition of the metabolism of CBZ by valproic acid results in an elevation of the metabolite CBZ epoxide, which increases the risk of the toxicity. Cimetidine Other examples include inhibition of phenytoin and the CBZ metabolism occurs by famotidine and as well as erythromycin. Practitioners must inform the patient to assess for adverse toxic effects. The most common reactions are rash, visual disturbances, drowsiness, and ataxia. Adverse and toxic effects are specific to the individual drugs. Abnormal thyroid function tests have been reported in patients on antiepileptics. The clinical significance of this is unknown. Agranulocytosis is rare but has been associated with the use of carbamazepine. Phthalate, baseline and periodic blood counts must be performed, especially for these drugs. You can check less frequently when the dose is stabilized. If febrile illness occurs or anorexia occurs, blood count and liver functions tests need to be assessed. This is especially true in children. For patient variability, geriatric patients, no specific guidelines have been put forth regarding the antiepileptics in elderly patients. All antiepileptic therapy is individualized and must be monitored carefully when therapy is initiated. Careful attention must be paid to those patients with hepatic or renal dysfunction. Lower, less frequent doses are needed for those with hepatic or renal dysfunction or other comorbidities. Many of the AEDs increase the patient's risk for osteoporosis because many antiepileptics are involved in the cytochrome P450 enzyme system. Care must be used in giving these products to patients who are taking multiple medications. For the pediatric patients, patients with febrile seizures are treated with phenobarbital, benzodiazepines, or valproic acid. Phenytoin and carbamazepine are not effective for febrile seizures. Valproic acid, clonazepam, lamotrigine, and ethosuximide are considered first-line medications of choice for children absent epilepsy. Valproic acid, lamotrigine, topiramate, levetiracetam, and clonazepam are preferred for juvenile monoclonic epilepsy. A pediatric neurologist should be consulted before any anti-epileptic therapy is initiated. Risks of recurrent seizure versus side effects of medications and compliance with long-term daily medications must be considered. The dosage of individual medications are based on the pediatric patient's weight and age. Pregnancy and lactation, all antiepileptics have been associated with an increase in birth defects. However, the use of antiepileptics has a profound influence on women in particular. In general, the risk of birth defects in babies of mothers with epilepsy is about 2 to 3 times greater than that of the general population. 95% of babies born to mothers on antiepileptics are normal. The frequency of birth defects is increased in untreated epileptic mothers, but the frequency of such events in mothers treated with AEDs also seems to be higher. Again, this is the risk versus benefits. All epileptic women of childbearing age must be informed of the risks before pregnancy occurs. Many serious defects occur during the first trimester. The most common defects include cleft lip and palate, cardiac septal defects, and neural tube defects. Children born to women who take valproic products during pregnancy have an increased risk of lower cognitive test scores than children exposed to other anti-seizure medications during pregnancy. An analysis of databases showed that children of women who took topiramate during the pregnancy had a 0.29% prevalence of oral clefts compared to 0.16% among children of former topiramate users. Although this sounds small, this is significant in in children. A neurologist who specializes in seizure disorder should be consulted before pregnancy to determine the need for medications. The frequency of seizures may increase, decrease, or remain the same during pregnancy. Alterations in metabolism occur during pregnancy that may affect serum drug levels of the antiepileptics. These are all information that the mother must know prior to becoming pregnant. Monthly follow-up and monitoring is required. Seizures and treatment with antiepileptics are not reasons to discourage pregnancy. However, the women must be made aware of the potential risks and outcomes. Care must be coordinated between the patient, the primary care provider, the obstetrician, and the neurologist to help the patient make the right decision for herself and the unborn baby. Antiepileptics, particularly barbiturates and hydantoins, have been associated with coagulation disorders in the neonate. Bleeding may occur in the infant during the first 24 hours after birth. Levels of vitamin K dependent clotting factors are decreased, and prothrombin or partial thromboplastin time is prolonged. It is recommended that vitamin K be given to the mother 1 month before and again during the delivery, and to the infant immediately after birth. Some antiepileptics are excreted in the breast milk, but serious adverse effects may occur in the nursing infant. The mother must make a decision whether to discontinue the medication or discontinue breastfeeding. Again, race, there is no special considerations required for the use of antiepileptics among the races. However, most participants in studies of antiepileptics have been white. Data on the use of antiepileptics in other races may therefore be inadequate. Gender, no specific differences have been noted between male and female patients regarding the metabolism and general use of antiepileptics. Seizures and their treatment may affect contraception, pregnancy, postpartum care, breastfeeding, and/or menopause. However, a few special considerations apply to women of childbearing age, which we have discussed. For patient education, the patient needs to know they should not abruptly discontinue seizure medication because it can precipitate seizure activity. You need to advise the patients of side effects and toxic effects and monitoring of side effects, such as bone mineral density. Antiepileptics may reduce the effectiveness of birth control pills. You need to counsel the woman who wish to become pregnant about the risks and outcomes. The risk of birth defects is greater in babies of mothers with untreated seizure disorder, as well as in babies of mothers who take antiepileptic medications. Some antiepileptic medications are excreted in breast milk. All seizure medications can cause drowsiness and can impair concentration. Advise the patient not to go swimming alone and avoid other situations that could be dangerous should the patient have an adverse medication event or seizure. Sleep deprivation, fever, stress, medications, and alcohol can lower the seizure threshold. The patient should wear a medical alert bracelet to identify the seizure disorder. Advise the family about how to protect the patient from injury during a seizure. Help the patient to the floor, keeping him or her away from any objects that may be bumped. Protect the airway from aspiration by using left-sided lying position if possible. Do not place any objects, including fingers, into the patient's mouth. Advise about driving regulations within the state. Most states require a seizure-free period before driving can be resumed. Healthcare providers should be familiar with the state regulations and should have contact at the Motor Vehicle Administration. Give information about national organizations and support groups, and do not use with alcohol because it may increase the CNS depression effect of the antiepileptic. We'll now move on to anti-Parkinson's agents. Parkinson's disease is the most common neurodegenerative disorder after Alzheimer's disease. The prevalence and incident rates of Parkinson's disease increase with age, and the incidence in men is significantly higher, about 1.5 times than that in women. Like Alzheimer's disease, Parkinson's disease is not curable. Symptoms progress and worsen over time. A neuroprotective treatment that can slow or halt disease progression has not yet been established. Parkinson's disease treatment is complex owing to the array of motor and non-motor features combined with early and late treatment adverse effects. Treatment for patients with Parkinson's disease is highly individualized. Again, these are the patients that should be seen by the neurologist, and you as the primary care would be monitoring. For the medications, most of these are dopamine precursors, monoamine oxidase B inhibitors, glutamate antagonists, antivirals, dopamine agonists, anticholinergic agents, and catechol-O methyltransferase inhibitors. Indications for use: idiopathic Parkinson's disease, symptoms of Parkinsonism, rivastigine has been approved for the management of mild to moderate dementia and has also been useful in the treatment of Parkinson's disease. And these medications also have unlabeled use for restless leg syndrome. Drug treatment for Parkinson's disease has centered on increasing the availability of dopamine in the central nervous system, inhibiting the effects of acetylcholine, and attempting to prevent further cell membrane damage through neuroprotective trials. The D2 receptor subtype is a primary modulator of both clinical improvement and adverse reactions such as dystonia and hallucinations. Increased levodopa precursors and synthesis of cofactors usually are not effective. Levodopa has been the single most important drug in the anti-Parkinson's medications. Levodopa administered orally enters the blood after it's absorbed from the GI tract, and 95% of the levodopa is converted to dopamine by LAAD. The action of this enzyme can be blocked by the agonist carbidopa, which does not cross the blood-brain barrier. Therefore, levodopa in the CNS follows the synthetic path to dopamine formation and storage. Combining carbidopa with levodopa results in increased concentrations of levodopa in the CNS and decreased conversion of L-dopa to dopamine in the periphery, where it causes adverse effects. Selgiline, also called deperanil, an MAOB inhibitor, is used with other drugs early in the management of idiopathic Parkinson's disease. The mechanism of action is not fully understood. These drugs inhibit the enzyme MAOB, which breaks down dopamine in the brain. The MAOB inhibitor causes dopamine to accumulate in the surviving nerve cells and reduce the symptoms of Parkinson's disease. Studies have shown that this can delay the need for levodopa therapy by a year or longer. When these medications are given with levodopa, they appear to enhance and prolong the response to levodopa and may reduce wearing off. Other MAOB inhibitors have been approved for the use in treating patients with Parkinson's disease. Patients with recent severe brain injuries treated with daily doses of Parkinson's disease drugs, amantadine hydrochloride, improved faster than those in the placebo group, according to the New England Journal of Medicine. Selective MAOB inhibition irreversibly blocks the metabolism of dopamine in the brain, where MAOB is the major subtype and extends the duration of action of L-DOPA. Selgiline often permits dose reductions of L-DOPA and increases duration of effect by 1 or more hours in patients who experience wearing off effects of L-DOPA. Rosalgilline may delay the use of carbidopa-levodopa in the early stages of Parkinson's disease via the same mechanism. Razagiline is classified into 2 major molecular species, A and B, and is localized in the mitochondrial membranes throughout the body in nerve terminals, brain, liver, and intestinal mucosa. MAO regulates the metabolic degradation of catecholamines and serotonin in the CNS and peripheral tissues. Blockade of the MAOB reduces metabolism of dopamine, but not that of norepinephrine or serotonin, and inhibits MAOB in the human brain. The exact mechanism whereby it causes an increase in extracellular levels of dopamine in the stratum is not known. For the dopamine agonists, these drugs, which include the bromocriptine, apomorphine, pramipexole, and ropinirole, mimic the role of dopamine in the brain. They can be given alone or in conjunction with levodopa. They may be used in early stages of the disease or later on to lengthen the duration of response to levodopa in patients who experience the wearing off or on effects. They generally are less effective than levodopa in controlling rigidity and the bradykinesia. Dopamine agonists are used in the treatment of patients with IPD to increase the availability of dopamine in the central nervous system. These drugs work at postsynaptic dopamine receptors in the nigrostriatal system by stimulating dopamine receptors. They are being used more often in early Parkinson's disease to avoid using high doses of levodopa in the late stages of the disease to aid the management of levodopa dose-response fluctuations. Pramaxole is a non-ergot dopamine agonist with specificity for the D2 dopamine receptors. It binds with lower affinity D3 and D4 receptor subtypes, and the relevance of D3 receptor binding in Parkinson's disease is unknown. Anticholinergic agents are used to control tremors caused by excessive unopposed acetylcholine. They suppress central cholinergic activity and may inhibit reuptake and storage of dopamine in the central nervous system, thus prolonging the action of dopamine. They also reduce the incidence of severity of akinesia, rigidity, and tremor by about 20% and may reduce drooling. The COMT inhibitors are central and or peripheral blockers of dopamine metabolism. COMT stands for catechol-O-methyltransferase, another enzyme that helps to break down dopamine. 2 COMT inhibitors have been approved to treat Parkinson's disease in the United States. These drugs, which prolong the effects of levodopa by preventing the breakdown of dopamine, are used in adjunct with levodopa to extend the therapeutic effect in patients who experience breakthrough tremors prior to their next dose. The mechanism of action probably is related to its ability to inhibit COMT and alter the plasma pharmacokinetics of levodopa. The administration of these drugs in conjunction with levodopa and carbidopa produces more sustained plasma levels of levodopa than does the administration of levodopa and carbidopa alone. The sustained plasma level may result in increased therapeutic effects on the symptoms of Parkinson's disease, as well as increased adverse effects. A decrease in the levodopa dose may be required. Amantine has been used for many years and appears to be potent CNS dopaminergic response, may potentiate a CNS dopamine response. It may release dopamine and norepinephrine from storage sites that inhibit the reuptake of dopamine and norepinephrine. It is clearly less effective than levodopa, but can offer additional benefit in patients experience maximal or waning effects from the levodopa. It has also been used for treatment of acetaminophen-associated dyskinesia. Rivascamine is available as an oral or transdermal system Exelon patch for the treatment of patients with mild to moderate dementia associated with Parkinson's disease. For treatment principles, the cardinal points of treatment, the initial drugs, first line include levodopa, dopamine agonists, carbidopa, levodopa combination. All patients will eventually need. This has been found to be most effective. The MAOB inhibitors, Salgilene has a modest effect, where Razagilene is thought to be effective as initial monotherapy or as an adjunct to levodopa, carbidopa, to shorten end of dose wearing off. Dopamine agonists are less likely than levodopa to cause dyskinesias or motor fluctuations, and may be given with or before the levodopa. Promaxiol and roperinol are effective in the early and late Parkinson's disease. Injections may be used for acute treatment of episodes of immobility known as freezing, and this is done with apomorphine. Anticholinergics reduce tremors, rigidity, and drooling. These are the older drugs with limited use. And the COMT inhibitors reduce motor fluctuations in patients with advanced disease, but they may increase dyskinesias, often used to treat wearing off with sediment. There is a black box warning from the FDA indicating that all antipsychotics, especially the newer drugs such as Seroquel and Abilify, should not be used in patients with Parkinson's because these drugs appear to increase the risk of death in older dementia patients. For non-pharmacological treatment, the impact of Parkinson's disease treatment regimens on patients' health-related quality of life is an important healthcare matter to address. The quality of life questionnaires provide insight into the management of disease from the patient's perspective and help the clinician to assess treatment efficacy. Several studies over the past few years have investigated the quality of life of patients with Parkinson's disease. All found depression to be a significant factor in terms of quality of life. Management of Parkinson's disease should include programs designed to optimize the patient's general health, nutrition, and emotional and neuromuscular status. Non-pharmacological treatment is very important. Group support, exercise, education, and nutrition can help. Patients may experience constipation initially, may gain weight if their activity level decreases. With progression of disease, patients may have trouble chewing and swallowing and may need to change their sitting position when eating. They may need to take small bites and chew well. They may need to drink plenty of water between mouthfuls of food and avoid certain foods such as raw vegetables and nuts, which may be more difficult to chew and swallow. There is some research suggesting that taking caffeine pills equivalent to about 3 cups of coffee per day may help with the motor symptoms in some patients. However, it does not significantly improve daytime sleepiness. It's customary for levodopa preparations to be dispensed with instructions to take with food. In fact, they may be better and faster absorbed on an empty stomach, but it's often advised that they be taken with food if they upset the stomach. Amino acids and proteins can compete with levodopa, which is also an amino acid, for the transport from the gut to the bloodstream and from the bloodstream to the brain. Most people tolerate levodopa without nausea and are able to take their levodopa medications before meals. For some people, this may occur 1 to 2 hours before eating, whereas others find it better to take their medication 30 minutes before eating. Some people find that avoiding high-protein foods during the day and hoarding them until the evening ensures better mobility during the day. Red meat, poultry, fish, milk, cheese, and eggs are all high protein. Often individuals benefit from combining small amounts of protein with high levels of carbohydrates, such as fruit, bread, cereals, pastas, and other grains throughout the day. Keeping fatty foods to a minimum also may help. Physical therapy can be very beneficial to keeping the patient mobile and keeping the weight down, and deep brain stimulation has proved effective in controlling the symptoms of Parkinson's disease. Other surgical techniques are being used in patients who do not respond to medications or who remain symptomatic. For pharmacological treatment, the NINDS has classified medications for Parkinson's disease into 3 categories. The first category includes drugs that work directly or indirectly to increase the level of dopamine in the brain. The drugs most commonly used for Parkinson's disease are dopamine precursors, substances such as levodopa that cross the blood-brain barrier and then are changed to dopamine. Other drugs mimic dopamine to prevent or slow its breakdown. The second category of drugs for Parkinson's disease affects only neurotransmitters in the body to ease some of the symptoms of the disease. For example, the anticholinergic drugs interfere with the production or uptake of the neurotransmitter acetylcholine. These drugs help to reduce tremors and muscle stiffness, which can result from the presence of more acetylcholine than dopamine. Third category of drugs prescribed for Parkinson's disease include medications that help control the non-motor symptoms of the disease. This is the symptoms that do not affect movement. For example, with people with Parkinson's disease-related depression may be prescribed antidepressants. The timing of treatment initiation in Parkinson's disease generally is guided by the impact that the disease has on the individual's quality of life. Over the last decade, a paradigm shift has been noted from initiating symptomatic treatment with levodopa, the gold standard of Parkinson's disease treatment, to beginning treatment with a dopamine agonist, in particular for young onset patients who are at risk for developing motor complications, and adding levodopa as a supplement when dopamine agonist monotherapy can no longer provide satisfactory control. Long-term levodopa treatment is associated with the development of motor complications that probably are initiated by abnormal pulsatile stimulation of dopamine receptors via intermediate administration of agents with short half-lives, such as levodopa. Dopamine agonists with longer half-lives can provide relatively continuous stimulation and possibly can diminish motor response complications. However, treatment with levodopa still is preferred in patients with Parkinson's disease with cognitive impairment, in the elderly, and in those with atypical Parkinsonism. Guidelines put forth also recommend dopamine agonists as alternative first-line treatment options to levodopa for appropriate patients. Safety and efficacy data show that several drug treatments can be considered as clinically useful and possibly useful for controlling motor features in early and advanced Parkinson's disease. Levodopa was found to be more efficacious than most other medications. Orally active dopamine agonists are very similar. The choice among available treatment options depends on clinical characteristics such as the patient's age, disease severity, and presence of comorbidities, as well as patient's lifestyle characteristics and preferences, costs of different medications, awareness of perception of available treatment options, and educational background of the treating healthcare provider. The immediate release formulation of levodopa is preferred over controlled release preparations for measurement of assessment of the therapeutic effect. The switch then can be made to a controlled release preparation. Therapeutic controversy revolves around the duration of levodopa therapy. Some practitioners believe that levodopa therapy is useful for only approximately 5 years and should be withheld until disabling symptoms appear. The sustained release formulation of levodopa may provide a more physiologic replacement of dopamine than is provided by the other regimens. An immediate release dose may be added to the morning dose if a patient experiences late onset or inadequate peak responses. The occurrence of blepharospasms or involuntary movement signifies that a dose reduction is needed. Again, you must consult with a neurologist, confirm the diagnosis, and give and receive guidance with medication management. Factors useful in assessing the need to start treatment include which hand is affected, the dominant or non-dominant hand, the patient's employment status, specific Parkinson's syndromes, symptoms, bradykinesia, or more disabling is more disabling than tremors, the individual patient's sentiments, and the individual prescriber's philosophy. Other factors include age. Patients younger than 65 years should be started with dopamine agonists, whereas treatment for older patients should be initiated with levodopa. Older patients are less likely to develop levodopa-related motor problems. Anticholinergics are contraindicated in older patients because of the increased risk of cognitive impairment, blurred vision, and dried mouth. Another factor is cognitive impairment. Treatment with levodopa should be initiated and polypharmacy eliminated through gradual discontinuation of drugs in the following order: sedatives first, anticholinergics, amantadine, selgiline, and dopamine agonists. You also need to consider disease severity. Is it acceptable to start with levodopa, and to move to a dopamine agonist if needed? You need to consider employment status. Dopamine agonists could be used first, especially in younger patients who are at greater risk of developing motor complications. Other experts advocate starting with levodopa. Another issue to consider is cost. When financial realities outweigh the potential for future benefits, initiate treatment with the least expensive medications. Cost is a significant variable for patients. Some medications are not covered on insurance formularies. Newer medications tend not to be covered by Medicare plans. Some type of prescription assistance programs may help some of the patients pay for their prescriptions, and you should become familiar with these if you're treating a large group of patients with Parkinson's disease. Combined therapy needs to be considered when patients treated with a single agent, either levodopa, or dopamine agonists, require additional treatment. Most experts agree that they should receive combination therapy rather than an increased dose of their current drug. As Parkinson's disease progresses, neurons lose their storage capabilities for dopamine, and the patients are dependent on the rate of levodopa administration for a therapeutic response. Approximately 50% of patients treated with levodopa will experience fluctuations in their response to the drug within 5 years. These fluctuations include wearing off, also called end-of-dose failure, as well as on-off effects, dyskinesias, and dystonias. Patients may experience wearing off of therapeutic effect after 1.5 to 2 hours with some products. On-off effect is a sudden loss of therapeutic effect. One treatment option is to give more frequent doses of levodopa or a sustained release formulation. If onset of action is delayed, levodopa may be given on an empty stomach before meals and crushed or chewed and taken with a full glass of water. Patients who experience chloroform dyskinesias during the peak levodopa effect may benefit from substituting an immediate release for a sustained release product, or the opposite. Amantadine is helpful in patients in whom dystonias occur at the end of the dosing cycle. They may benefit from more frequent doses of carbidopa-levodopa or from addition of or increase in the dose of dopamine agonists. Restriction of carbidopa-levodopa for several early to midday doses may also be of benefit. Early morning foot dystonias may improve as the result of nocturnal administration of sustained released carbidopa-levodopa. If this is not successful, a nocturnal dopamine agonist or an early morning carbidopa-levodopa or Paracopa could be used. Patients with dystonias that occur at peak dose time may benefit from lowering the dose of carbidopa-levodopa or from addition of or increase in the dopamine agonist dose. How do we monitor this? In general, no laboratory tests are used to monitor the efficacy of anti-Parkinson's drugs. Expectations are discussed with the patients and their family. Again, there is no cure for this disease. However, symptom management is the goal. With the use of physical assessment measures of neurologic function, patients' response to therapy in the presence of side effects. These are monitored by assessment of their functional and clinical status. Regularly assess the facial appearance, salivation, seborrhea, speech, tremors, rigidity, dyskinesia, finger-foot tapping, rapid alternating movement, standing up from a chair without assistance of arms or hands, postures, stability, gait, handwriting, and intellectual and psychiatric assessments. The most common adverse effects of anti-Parkinson drugs are nausea, hypotension, and psychiatric problems. These symptoms should be monitored continually. For patient variables, we touched a little on geriatrics. For pregnancy and lactation, most anti-Parkinsonian drugs are categorized as pregnancy category C or unknown. Excretion in breast milk is unknown or does occur. Therefore, avoid using any anti-Parkinson drugs during pregnancy or lactation. For pediatrics, safety in children younger than 12 of age has not been established. And for patient education, most importantly, support of emotional needs of both patients and caregivers is essential. Patients, families, and significant others should be educated about realistic expectations of the various treatments. Encourage patients and their families to adhere to their treatment regimens and keep a diary of their symptoms and daily medication administration times. Patients and family members will need extensive counseling and education regarding maintaining health, nutrition, and physical activity. They will also need to have to devise particular strategies that they can use to deal with the psychiatric problems that may occur as the disease progresses and worsens. The National Parkinson's Disease Association offers many resources for providers, patients, and families, and this can be found on the internet.